Friends, I am Dr. Amdekar, and in this forthcoming series, we are going to address 6 different issues which are very important in a clinical bedside medicine. And in this first of its kind, in the first video, I am going to discuss how a good history can anticipate a physical findings. Friends, you know that history has a power to arrive at a provisional diagnosis almost to the extent of 80 to 85% of the times. But beyond that, the good history can also point out and anticipate what physical abnormal findings you are likely to find. And this is the fun of a detailed good history, and what a power of such a history. Well, we know that the examination starts with a look at the patient. The history itself can foresee what kind of look your patient is likely to show you. Would he be acutely sick, chronically sick, or really not sick at all and fairly comfortable? But most important point that you may not have taken a note of is that a good history can even anticipate the weight and height of the child, and so also the head circumference if required. How do you do that? I'll give an example. If a 4-year-old child should normally have 100 centimeters as his height, but your given patient has almost the normal height, but the weight is tremendously low, which means that this is the acute onset, very fastly catabolic, progressively getting worse, but the height is not affected because it has been a recent onset disease. On the other hand, if the weight has gone down but minimally and not so much, but the height is normal, then you know that it's a slowly progressive disease of not a very recent origin. History can suggest you that, and then you translate that kind of analysis into a probability of what the weight and height could have been. And friends, you can be almost closely right to a point of 1 centimeter plus or minus. That's the power of history. I don't mean you don't not measure the proportion, but this is the power. And then when you get on to all the details, you would know that, for example, you have a developmental delay. You can almost anticipate the entire likely physical findings in a given patient, whether his skull would be small or large or normal, whether he would have some paresis, would his tone be normal or spastic or hypotonic, and would there be any cranial nerves abnormalities, and whether there would be any signs of increased intracranial tension. All can be anticipated merely by a good history. Take an example of the abdominal distension, for example, going on for some time along with a general weakness, which almost means that the child must be very pale, and if he has an abdominal distension as well, then he has a severe pallor with hepatosplenomegaly. If he is reasonably comfortable but short, then you know it's likely to be a congenital hemolytic anemia. And if your history suggests that there was a mild icterus as well, then you know it's almost a spherocytosis. And then you get the history of the parents, and you find that one of the parents would be also small and may also have a spherocytosis, the disease being autosomal dominant. But if such a child has no such history, no jaundice, then you know it could be a thalassemia major. And if such a child is very sick looking, of a recent onset, then you know that it could be a bone marrow infiltration, maybe leukemia or whatever. Similarly, when you have a severe cough, you anticipate findings on the airway, largely bilateral. But if you are suspecting pneumonia on your history, then you expect a localized findings, almost of impaired note or a bronchial breathing or a localized crepitations. And if you get into the details of the history to fish out the chest pain, then you know which lobe, which side is involved in terms of pneumonia. And if this very patient who looks like pneumonia on a history suddenly gets worse in terms of high fever and gets worse in breathlessness, then on examination you would anticipate findings of a pleural effusion, empyema, under which would be hidden findings of pneumonia as well. And if you look at a cyanotic heart, for example, you would easily be anticipate on good history whether it is going to be a hyperemic or oligemic lung fields, and knowing that, you could further get on to the details of when did it present for the first time, was cyanosis deep, was there a cardiac failure or not, and you could easily anticipate physical findings suggestive of a TGA with or without pulmonary obstruction, or maybe a single ventricle, or maybe a Fallot's tetralogy with a silent precordium. What a power of anticipating abnormal physical findings. And if you are looking at the short stature and the child is absolutely healthy, normal, but he's short, likely he has either a GH deficiency, growth hormone deficiency, or it could be simply a genetic short stature, or even possibly constitutional. That means he will get finally a reasonably good height. And on the other hand, if he is a lethargic and little mentally dull, then you know that it's likely to be hypothyroid. And if he is otherwise alright but short stature with some bony defects or abnormalities, then if it's an infant or a toddler, it could be simply a deficiency rickets. But if he's failing to thrive, on the history itself, you know it's likely to be a resistant rickets. And if nothing of that kind but otherwise happy, then you know it could be a chondrodystrophy or a chondroplasia. Similarly, the renal problem, you can almost anticipate when the history suggests nephrotic syndrome that this child would be severely bloated all over with edema, and then if he has a mild edema that you're suspecting acute glomerulonephritis, then he would also have hypertension. That is the power of a good history. Friends, we know all this, but we tend to ignore it, and then we miss it, an important contribution to your good diagnostic skill. And why do we not pay attention to it? Simply it's not in our mind. We must develop that kind of passion, exclusive of what others appreciate or not, but inclusive of your own happiness. And it's the attitude that we must develop. And what is this attitude really means? It's a triad of belief, action, and outcome. You believe in God, so your action is you pray, and your outcome is you feel happy and contented. Similarly, in medicine, you must have an attitude to excel in your diagnostic skills, and for which you must believe in yourself. You must develop that kind of mind, and it's all emotion. You know that emotional circuits in the brain of the mind are the muscles of the mind. And if, like the muscles that you develop with practice in a gymnasium, these kind of muscles, emotional circuits can be developed with practice. And when you practice developing such mind, then you get that kind of a thrill of even anticipating physical abnormal findings. And then finally, friends, what's the idea of doing all this? If you could anticipate some physical findings and then you actually perform physical examination, and if you find that both were fairly identical, then you have almost got a final diagnosis. And then you can just choose a very minimum selective investigation to confirm the diagnosis. It would mean rational and excellent bedside practice. And this is the way to learn clinical medicine. But if your anticipation and actual findings are dissimilar, then you go back to find out which clues you missed in the history or which examination findings you overlooked. And again, therefore, trying to anticipate all these findings makes you learn medicine much better, and I think it will be ultimately very useful for our doing good to the patient. Friends, I'm sure you agree to all this. Let's start doing it, and the subsequent videos will take you on similar issues which we often face in clinical practice, and based on a good history and good examination, sometimes one is there, the other is not supporting, we would learn a lot. I hope you enjoy this series and be with us. Thank you very much.